Hangout is on the air. My name is Shira Goldberg, the hostess with the mostest. I have with me someone who is an author and a doctor, same person. His name is Dr. Gerald Fishkin. Why is he on the show? Well, because he is very important in the realm of shame. He's an expert, and it's something that I'm very, very interested in. So especially in the realm of addiction recovery. So Dr. Gerald Fishkin, thank you so much for being here.
Good morning. Thank you for having me, Shira.
So why are you an expert on shame?
Well, I think my expertise really started with my first internship back in 1966 as a VA intern in psychology. It was a neuropsych 2-year internship. And from that time on, I've always been interested in how our brain influences our behavior and how it interacts with us and how we continue to learn and grow as individuals. So my interest in shame really started somewhere around 5 years ago when I was introduced to John Bradshaw and Pia Mellody and Claudia Black, who were thought leaders in the area of addiction and trauma. When I began to go through certain programs at the Meadows to find out what they knew about shame, I realized that there wasn't really a lot of information. It was more anecdotal and contemporaneous than science. So I started a pursuit to understand what this thing called shame was. I began to realize that in my own clinical practice, when I'm dealing with addicts or people who have addictive disorders, and we get to a certain place with regard to early life abuse, trauma, neglect, violence, they would either freeze or bolt from treatment, and they would never finish the therapy. So I wanted to understand what this process was that caused them to leave. And as I did my reading and pursuing this shame issue, I got to see that shame really lives in the brain, and it lives in the basal ganglia of the brain. Again, bringing back all my early neuropsych work. Dr. Antonio Damasio at SC and his team of neuroscientists actually were the first to pinpoint that shame lives in the brain in the basal ganglia, which is just above the limbic system, the seat of emotion. And as I began to pursue this, I found that it really kind of had a dead end. And I wanted to understand this as a personality theorist and a neuropsychologist. I kind of felt that there is meat here, and I got to find out where the bone is. So as I continue to pursue this, I found that self-talk, which is really the part of shame that we hear, and then the affective part of shame played such a critical role, but nobody had really written about it. So as I began to pursue the literature, not only in the United States, but across the pond into Europe and such, I saw that nobody had really done a lot of this, again, anecdotal, contemporaneous information. I began to see the relevance of the neuropsych stuff, the neurology, and the perceptual and cognitive pieces here with shame. I saw that cognition plays no part in shame. Actually, shame is an affect. And as I started to look at affects, nobody had really talked about affects. They only talked about affects in generalizations. So that is really where I began this process. In fact, the first few drafts of my book were called Self-Talk and the Architecture of Shame. And as I began to develop this and look at it and put all the pieces together, I actually realized that I had a science here more than just a collection of data and pieces. It actually shows the science of shame in terms of where it is located in the brain, how it operates on us, and how we can actually deal with it. But more important, I began to understand that our traditional ways of dealing with shame, including cognitive behavioral therapy, did not work. And that's why my patients were bolting at a certain point in therapy.
So for the layman, how do you how do you explain, because a lot of people don't know what CBT is and how shame relates to it or not. So just for the person on the street, how would you define that for them so they can understand their own therapy?
Sure. Shame, when we have a shame attack, and let me just kind of back up. Folks that have early life trauma, neglect, abuse, violence, anything that's destabilizing and considered abuse, as they grow and mature, the shame factors tend to expand and tend to control the individual's life in terms of self-talk. Individuals who suffer from chronic toxic shame with addictions often never really feel good about themselves. They absolutely suffer what I consider to be the 10 greatest fears that a person can have. Those being fear of being abandoned, not being good enough, going crazy, losing relationships, being a failure, fear of being a failure, fear of the emptiness that many people with toxic shame experience. More important, displeasing someone, being seen as a phony, not mattering. I think not mattering is huge. And then, of course, being shamed. So these issues with the person who suffers toxic shame are paramount, and that's what they hear. When we use cognitive behavioral therapy works with cognitions that cause a person to feel bad about themselves. Those are the cognitions. But affects and toxic shame really is precognitive. It functions at a very basal level. And there is no pre-warning when we have a shame attack. It just happens to us. As with cognitive behavioral therapy, we could certainly take our time and deal with how a person thinks about an activating event, and then their belief about that event, and then the consequential behavior or thought. That's cognitive behavioral therapy. It works at a much higher level of the brain, whereas with toxic shame, it works at a very basal level of the shame of the brain. And if you look at the diagrams in my book, it will really identify and show exactly all of these parts and how they fit together.
How do you think, like understanding the anatomy of the brain and the reptilian brain, the limbic system, and cognitive behavioral therapy, like what does this mean for someone who is actually experiencing toxic shame based on things that have happened to them?
Right. Well, with toxic shame, Shira, what we have are what I call limbic hijacks. And that is where a person is so vulnerable because of how badly they feel about themselves, which is really not anything that they did. It's typically the effects of early traumas inflicted by others. So when a person has a shame attack, it is they want to disappear. It's nothing to do with cognition. The cognitions come later. The shame attack is paralyzing and inhibitory. When a person has a shame attack, all they want to do is escape, or they are frozen in time and space. And to me, that is the horror of this process. And that's what I see in treatment too. When a person reaches a certain point in therapy and they begin to have these shame attacks or show them in treatment, the therapist has to really be committed to understand what this means. It's a different kind of treatment. It's a treatment that I call a compassion-based therapy, where we are looking at what is compassion. And again, in the book, I break down compassion. And typically we look at compassion as a feeling. Well, compassion really isn't a feeling. I think compassion is a secondary affect. And I think compassion is comprised of two factors. One is attunement, that is being attuned to the individual on a pre-verbal kind of non-cognitive level. And the other one is empathy. And empathy really has to do with empathic understanding, and that is knowing the person, which is a bit more on the cognitive level. These two components, when they happen, create compassion. And compassion in treatment is a form of relationship with your patient at a different level than doctor-patient. We're more relational when we're treating a patient using compassion-based therapies. Later on in treatment, cognitive behavioral therapy may be able to be used to deal with certain aspects of cognition. But in the very beginning of treatment, when we're dealing with addictions especially, we have to use a compassion-based treatment approach. It is paramount.
So walk us through that. If someone were to be your client, how would they start this?
Well, I don't use the term client at all. I really, they are my patients. If I was selling real estate, they'd be a client. But I could be sued for malpractice. I think they call the patient. I pay a lot of money for my malpractice insurance. So when a person comes in to me, the first thing I want to do is take a complete history, as we are supposed to do, and understand the traumas in their life. That may take quite a while. It usually takes maybe 2 to 3 months to get a complete history. And then if they're able to talk about the early wounding, often these wounds have to do with being sexually abused or violated in some way. For some patients, it's the first time they've ever really talked about what happened to them, because they've spent their whole entire life covering the wound and protecting the wound, because they feel like they created it. And it is my belief that no, they were victims, 2 adults. And until a person is 18 years of age, I think they're just children. And I think that they are not really totally responsible for what they do. After 18, I think we can begin to look at adult responsibility. But for many of these folks, it's the first time they've ever really had the opportunity to talk about their wounds. Sometimes in the beginning of treatment, I'll have them write a letter to the abuser. It may be a family member or someone that they knew, someone that was a neighbor, someone that abused them early on, and that abuse stays paramount in their psyche. So I'll have them write a letter to their abuser and talk about and have them really express to the abuser, whether they mail the letter or not, what their feeling was and what they did to that, and what that my patient feels about that experience. Sometimes that is the most profound effect that the individual will ever have in their life, and it is the way of opening the door to getting deeper into their affective system, if you will, so that they can openly discuss how bad they feel.
I think a lot of people who are suffering from addiction or are interested in recovery often traumatize themselves through the lifestyle, quote unquote. So how are you able to help them understand the placement of shame and where they're responsible, but also to move forward? Because I think that's a lot of the problem when someone is interested in recovery, but they're just so unavailable to themselves as far as expressing emotions, and especially if they feel like they're to blame.
Right. And I think what I see most often, and I've been doing treatment since 1970, so it's about 46 years, is that once the individual truly understands that they are not responsible for those early traumas, that those traumas were inflicted upon them, it's really the opening the door of self-acceptance. When we can really what I call pin the tail on the donkey, and really assign blame and responsibility to the other, then my patients really begin to feel as though they can own their new healthy life and begin to take chances and risks with new behaviors and become a bit more self-promotional, if you will, or advocating for themselves, or asserting their self in different ways. And that's what I see in treatment. They become less inhibited, less confined by their own self-talk and their own feelings of inadequacy and their own feelings of disgust and despair. when we can get them to understand that it's not their fault, if you will. You know, and that there's and I think I may have mentioned this on an earlier show, that there's a scene in Good Will Hunting where Robin Williams puts his arms around Matt Damon and says to Matt, it's a very emotional scene where he says, it's not your fault. I mean, any of us who have seen that scene or seen it over and over get it. We get the fact that those words are so profound. It's not your fault. Then we can begin to deal with what I call, developing a better sense of self. And I think that is critically important to the whole therapeutic process, Shira.
Why do you think shame is so prevalent in our society?
Because of the lack of bonding, and I think the lack of the two-parent household. And I think people are so busy living their lives that they don't really spend the time necessary to treat their children with the kind of understanding, respect, love that a child needs, the kind of compassionate understanding that a child needs. Many of the children, or many of the adults that I treat, even the teenagers and some of the children, come from abusive homes where there is only one parent. Maybe they were in foster care. Maybe they were abandoned early in life and they were adoptees. But oftentimes these children don't feel connected. They feel totally disconnected, not only from others, but especially from themselves. And I think that the fact that 50% of all marriages in our country end in divorce, is the telltale sign that we have a huge problem in our country. We have a lot of disenfranchised children who don't feel connected to anything. I saw a special last week on TV on ISIS and ISIL and who these radical Muslims are. And many of them are just like the kids I treat or the adults that I treat. They're disenfranchised. They come from a single parent family. They're looking to attach to something, and they're given something greater than who they are, something greater to believe in, something to help them feel that they're important. Because again,
and also that sense of belonging, I think we've lost that in our culture.
Sure, you hit the nail right on the head. It is that sense of belonging and that sense of attachment that's lost very early in life that we need to get back. And the child or adult needs to feel that they have an effect, that they are attached to something greater than themselves, and that they matter.
Mm-hmm.
That they matter. That they feel connected to who they are. That's critical.
Yeah, everyone needs to feel seen, heard, and valued. That's what I've learned.
Without question.
Mm-hmm.
We all need that to survive. Harry Harlow in the late 50s, when he was doing his experiments on rhesus monkeys, actually showed that these monkeys that he was doing experiments with, and I won't get into it, but I really defined it quite well and summarized it in my book, showed that these monkeys would attach to their wire mothers more importantly than even having food. The attachment to a warm mother was more important than nutrition. How profound is that?
Yeah, although that was a highly unethical experiment, poor little monkeys, but we still get the information from it today because we see it. When someone is interested,
I didn't say that his research was ethical. that his findings were incredible, and that they are applicable today.
Yeah. No, I get it. I use the Harlow experiment quite a bit. So I mean, it does show that but I do feel bad for these poor little monkeys.
I feel terrible for those little research monkeys. But then again, I doubt that they're still around. That was like 70 years ago.
So when someone is interested in working through trauma, that seems to be a really important part of shame and how it's manifested, how we contain it, how we suppress it.
Right.
What are some tools for people that can't see you as a patient? How are they able to navigate through that?
Well, I would hope that they find, first read my book, and then I
Okay.
hope that they can find a therapist that practices compassion-based treatment. And certainly, if an individual is looking for therapy, they can, call, different therapists and assess the kind of treatment that will help them get to the core wound. And this kind of treatment is very much akin to dealing with PTSD, and it looks like PTSD
Hmm.
because of the repetitive nature of the thoughts, the dreams, the anxiety, and the despair.
And you talked about where shame is located, or where it originates in the brain, but how we carry it, how it affects us directly and indirectly.
Right.
It's really something that seems embedded in our psyche. So
Right. Again, you made a very good point. When you use the word carried, it is carried shame. But typically we're carrying the shame of the caregiver. We're carrying the shame of the parent who shamed us, or the father that violated us, or the priest, or the scout leader who violated us. Somebody did something to us, and we're carrying their shame. When we realize that it's not our shame per se, we can begin the emptying of the shame bag, and that is giving it up, letting it go, and allowing ourselves to test out new behaviors in a positive and proactive way, but also understanding and releasing that shame through a number of different things, whether it's hypnosis or guided imagery, or writing about it, or writing letters to the abuser. It's allowing ourselves to take action, to assert that wounded child into a healthy adult, so that we can begin the process of growing up. And typically, when when a child is abused or traumatized, they typically don't grow affectively or emotionally past that point. They grow certainly chronologically, but affectively, emotionally, they don't. They stay retarded, if you will. They can grow, but they tend to stay there and keep repeating the wound, as if, in a sense, trying to overcome it or undo it. But in the process of overcoming it and undoing it, and they stay stuck, they just reinforce the wound, and that's where they stay in that toxic shame state. My treatment approach, as I'm sure there are many others who I hope are doing this, is to get past that, to help empty that bag, to deal with that wound, and to cry, to do whatever is necessary, scream, yell, to work through that wounding process in order to grow up. And by grow up, I really mean get past where they are stuck and traumatized.
So my interest primarily is those that are in the recovery/addiction community. A lot of people weren't molested by priests and their fathers. The shame comes from the actions to get their drugs during their active addiction.
Right.
How do you help those people navigate?
Well, first and foremost, you're absolutely right. Shame is toxic shame, as I identified, are the addictions. And I think that most important, we have to get a person through treatment and chemical recovery first. So detoxification is really paramount at the beginning stages of this treatment. We cannot do therapy while a person is in the middle of their addiction. They have to be clean and sober before we can even attempt to do anything like what I'm advocating here.
So it's possible for people who haven't experienced trauma, say early on as children or adolescents, when the shame is imposed upon them, and that's how I see it, because it's just not quote unquote normal to become a drug addict and to maintain that lifestyle. So we're going against the grain of convention.
Well, actually, it depends upon the environment that the person's in. If they're in a toxic environment, if they are in the shooting gallery, that is normal. Those people are normal. If they're sitting in their favorite pub after work, getting drunk and being around those people, that's their normal, healthy environment. We have to get them through those toxic environments and through that. So there's I think there has to be a clearing in the woods in order to have a sense of sobriety, in order to be able to understand what this is all about. When a person's in the middle of their addiction, they don't understand. They can't, because they are, again, in the middle of their addiction, and their brain is being controlled by the drugs or the chemicals that they are addicted to. So, I mean, we have to get past all of that first and get past all that toxicity in order to begin the process of healthy psychotherapeutic treatment.
I'm really glad we're talking about this subject, because it really, I see it, it's such a prevalent concept in how it affects people that are trying to break out of their addictions and trying to live a life that is more prosperous and healthy. But it's like almost a magnet. They're so ashamed of their behavior while they were in active addiction. And they're not used to feeling their emotions or processing their emotions. So there's such a strong pull. I think that's one of the primary reasons for relapse. What do you think?
Yeah, absolutely. And I really do believe that we have to have a sober brain in order to get anywhere in terms of the addictive process. We can't have any more hijacking. The person has to have a period of, quiescence and quiet in order to really begin the process of change. They have to be able to look back and fill in those blank spaces of their memory where they had been traumatized. And once we can get past that, what I find too, and as I'm dealing with this therapeutically, we open the floodgates oftentimes, and they start to have memories of the trauma. They have memories of their early life that they didn't have before. And that again makes sense, because trauma is inhibitory. And once we can deal with that trauma, get past it, assign the blame, and begin the process of letting the self become the healthy self, because it's there. I believe it's like a tabula rasa. Whatever's written on ourself, we can write on it. We can unwrite it. We can erase it and write new stuff, because I think that's how life works.
So what you're saying is, even people that have trauma and have been involved in addiction can be released from that bondage.
Without question. And I see it over and over again. And that's why I wrote this book. And that's why I absolutely have absolute faith in the therapeutic process. And for many people, it's the first time in their life they ever felt good about themselves and were able to try and test, experiment with new behaviors, experiment with a new way of seeing themselves, and for the first time in their life begin that process of developing a happy sense of self, a healthy sense of self.
So let me show the book again. So where can we get your book? I had an advanced copy because I'm so cool, but where can other people get it?
It's available at Barnes & Noble. It's available at Amazon. It is available through the publisher directly, and that is an 800 number, 621-2736. And they can also go to my website, drgeraldfishkin.com, and that's drgeraldfishkin.com. I hope you have it up on your screen. Or they can, contact me through my website, drgeraldfishkin.com. They can also go to our new Facebook page, and it's called The Science of Shame and its Treatment on Facebook, and they can get all my videos and also order the book and see what we're talking about there.
Now, I just want to touch on this quickly. This is not your first book. What other books have you written?
This is my this is my fourth book. The first book I wrote was called Police Burnout, and that was the first book on police officers who burn out, and how I've spent years working with them and helping them through PTSD and their recovery. I really began to see this whole addictive process through the first work I did with police officers and their families and such. And that's really how this was all born anyway.
Well, you know, this has been such a true pleasure. I'm really happy that you were able to be on the addiction show and just explain in layman's terms the concept of shame and that we just don't have to carry it. It's not our burden.
Right.
Always a pleasure dealing with you, mister.
Thank you, Shira. I love talking to you. And I hope that your audience understands this. I'm sure they do. Especially if they're in the middle of the addictive process and they need help, please go to my website, drgeraldfishkin.com, or the Facebook page, and take a look at that and try to do the best they can to find the help that they need, a healthy recovery.
Okay, so that is Dr. Jerry Fishkin. His book is The Science of Shame and Its Treatment, and you can find him on Facebook. I'll put the links up, as well as drgeraldfishkin.com, although I know you like to be called Jerry, so that's what I call you.
Thank you,
So,
Shira.
hey, you know, a lot of people are looking for answers and ways to help themselves. I can't think of anything that's more supportive, compassionate, or empowering. So kudos to you, my friend.
Thank you so much.
All right, until next time. Peace.